Okay, good afternoon, everyone. This is Katie Kopp. We really appreciate all of you who were able to make time to jump on this call. We think we've got some information that's going to be really helpful to share and hopefully have some good discussion from you all too. I wanted to first just give a quick reminder that we've placed your line on mute, but you can press *6 at any time to unmute yourself. That's probably going to be the easiest way to engage with us. There's also the chat box if that helps you too. I wanted to also just give a quick reminder that this is our key driver diagram. This is what we're using to structure this initiative that you all are working on. And in just a minute, Dr. Patel is going to be walking you through this a little bit more, but I wanted to go ahead and highlight the Vaughan micro lessons that we're watching as a collaborative this month. It's going to be lesson number 6 and lesson number 9. And you can see the titles there, and I will send this out in an email as a follow-up too, but just wanted to go ahead and put it on your radar. And just a reminder too that there are some hospitals who are following a different schedule than the one that we've outlined. That's perfectly fine. So, but if you're one of the hospitals or you're following along with this schedule, we'll watch lessons number 6 and number 9 this month. Just any time in September before the next webinar is the pace that we've set. So that is, I'll give a few more updates at the end, but that was the main one that I wanted to communicate. So I will turn it over to Dr. Patel. He's an associate professor of pediatrics at Emory University and also with Children's Healthcare of Atlanta. And he's also been on the leadership team for GaPQC and working really hard to support you guys on this NAS initiative. So Dr. Patel, you can press *6 to unmute yourself.
Hi, Katie. Can you hear me?
Yep, we can.
Okay, great. Well, good afternoon, everyone, and thank you for the introduction. I wanted to spend kind of at the beginning, we're going to flip a little bit and talk a little bit about QI as it relates to all of your efforts to improve care of babies and mothers impacted by NAS, and really to focus on kind of 2 key aspects of QI, which are key driver diagrams and change concepts. And hopefully these can be tools that you use as you progress over the next 1.5 to 2 years and working on this, something that helps to kind of add some structure and focus on your initiatives. So what I hope is at the end of this kind of brief session that you'll at least understand the construct of a key driver diagram, how it can be used, and you just saw an example of kind of our big key driver diagram for this initiative, but also maybe a smaller, more focused one for the work you're going to be doing in your own hospitals. And also to then apply some change concepts and to kind of think about changes you can make to address some of those drivers and to test in PDSA cycles that we'll be talking about in one of the future QI discussions. So one thing that whenever I think of kind of our goal is really that we want to do the right thing for every patient every time. And this is what I think what QI is all about. It's providing evidence-based care equally and equitably and consistently. And this is, I think, what we're hoping that all of you will be able to do over this initiative as we work on improving the care for babies and mothers impacted by NAS. How well do we do that? This was really a landmark study that showed we don't do this really well. This looked at a large population of adults. This was led by the RAND, it's often termed the RAND study, that looked at how often did adults get evidence-based care they deserved, that they should have received when they went to go see their physician, things like getting a flu shot when it was indicated, getting appropriate heart medications if they had a heart attack. And this study showed it happened about 55% of the time, and really showed kind of a large gap with where we'd like to be with our care and where it actually is. And this has persisted in follow-up studies as well. So how do we address this gap? Well, this is where I think the model for improvement comes in. It's probably the most widely used model of QI in healthcare. There are other models that you may be familiar with and your hospitals may use, but I think that, and they generally have the same principles. And so right now, in this initiative, what we're hoping is that you all have formed a team, and that your team is sharing the opportunity to learn together using some of the Vaughan micro lessons as an opportunity for shared learning that you've been working on and have made aim statements. We've had a chance to see a couple of those, and Dr. Ranganathan has talked about aim statements in some of the prior slides. And related to those aims that you've set forth, establish some measures that you'll be able to track. And I think one of the first glimpses of those measures was the Vaughan Day audits, which allowed you to get a sense of where you start and where your baseline performance is, and may hopefully help you kind of guiding your teams to setting your aims for where you'd like to be, a year from now as you work on this over the next year, and setting those aims. But what I'd like to talk about today is really point number 4, and that's kind of identifying and selecting changes to test using process improvement tools. Some of you may already be starting on this. Some of you may have been thinking about this, but this is something that I think it's probably a good time to touch on as you've worked through the first 3 steps. And something really helpful that's kind of a really nice summary of tools you can use, and some of these we'll touch on as we go through some of our QI discussions over the next year are in this nice QI Essentials Toolkit, and we'll be sending this out or having this accessible to all the project teams. These are things that are tools you can use that are often used in quality improvement work that can help you as you try to improve. And so this is something that we'll be talking about. But for today, I wanted to focus on just one of the tools, which are driver diagrams. And this is an example of a driver diagram. What this is giving you and your team kind of a theoretical framework of what your goal is, what your aim is. In this example, it's to reduce colonization and infection with MRSA in this hospital by 50%. And what's driving that problem that you're trying to improve on? And it may be, what are the drivers? Well, one of the drivers is you could reduce transmission of infection and colonization, or if the patient's colonized, reduce infection. And each of these primary drivers have secondary drivers that may be things you can tackle: decolonization, screening patients, good hygiene. And each of these have change ideas, things in your own hospital that you may be able to try to do or change or apply and test that could address these drivers with the eventual goal that this is the way you're going to move the needle on your aim and get to improve your aim. One helpful thing about driver diagrams is that it can provide your entire group with kind of a shared understanding of what you're trying to do, and also to highlight kind of where you're working on, how the specific thing you're working on today or this week or this month relates to your kind of big picture overall improvement goal. So this is kind of the driver diagram we came up with for our kind of state efforts and how we've structured this initiative. With really our aim and our hope that across all of the hospitals, as kind of a group team, that we are able to reduce our length of stay from 11.2 to 10.1 days, so a little over 10% by the end of next year. So that should be 9/30/2021 in 2 years. And that global aim is to improve care of babies and mothers impacted by NAS. And each of those things in green are the primary drivers. These are the ways in which things that we can do to address ways that we can reduce length of stay. And each of those drivers have potential interventions that you and your centers can take on to try to achieve those drivers. And each of those interventions, there's micro lessons that tie into them that can give you some ideas of what things you can change. Some of the Vaughan Day audit data ties into some of these things. For example, if your aim is on increasing breastfeeding, there's data on policies regarding breastfeeding, and does your center have that? Now, there's a lot of different interventions to work on, and it's going to be very difficult for any center to try to address all of these drivers and all of these interventions. So sometimes you have to kind of pick and choose certain drivers, interventions that you're going to work on, maybe using your Vaughan Day audits to guide where you thought your performance, looking at kind of the benchmark of other hospitals to say these are the things we think we can try to address, or maybe these are opportunities you've already considered or maybe already working on to address. And you can highlight those in your driver diagram so that it can give you an idea of these are all the things, but this is what we're working on. Understanding you can't address every driver, or maybe over time you'll be able to address more drivers, but these are kind of the things you're going to be working on over the next 1 to 2 years. This is an example. You may have remembered Susan Ford from the Ohio Perinatal Quality Collaborative presented a few months ago, and this is their effort. You'll see a lot of similarities between what we created in their effort. One of the rules in QI is steal shamelessly, and we hope that all of you as centers can share what you're doing and others can learn from that. And this is where they realized all these drivers, and each of these then had interventions to address. So this is one example of a group working on, as a statewide collaborative, a key driver diagram. This is an example of a group at Yale as an individual hospital, what they worked on, again, trying to reduce length of stay, similar to most of the quality collaboratives where they want to hopefully improve care so that babies can get home sooner. And this was by Matt Grossman. He's also the person credited with developing the Eat, Sleep, Console approach, and this is part of how this emerged. And they wanted to reduce length of stay, and part of that was developing a novel assessment of evaluating infants, which is turned into kind of what is the Eat, Sleep, Console approach. This is a smaller, more narrow driver diagram for what an individual hospital was trying to do to try to improve their outcomes. Now, there's a couple of tools that we'll be sending out. This is a blank sheet that can sometimes help as you're trying to come up with your own key driver diagrams. This is from the Institute for Healthcare Improvement, where you can write in your aim and measures and primary drivers and secondary drivers. And this is a great way to, as you're starting your team meetings or getting together as a team, this is a great way to begin off by kind of reviewing this. And this should be a living document. So this, as you kind of learn more and understand your drivers better, what's causing prolonged length of stay or whatever focused aim you're working on, you can update this and add new drivers and expand your secondary drivers. So this is something that will evolve over time, but a nice way to kind of go back and use this as a framework for as you're working on this project. This is also a template. This is in the QI toolkit from the IHI that you can actually fill in. It's a fill-in PDF that you can use and print out, and this will be in that packet of QI tools that we share. And this will be a way for you to not only look at kind of your primary big ticket drivers and those secondary drivers that are related, but then also things that your group may come up with as ideas to test or changes to try. These may be things that you decide to pursue, or just maybe thoughts that the group has. It's good to be expansive when you're thinking of change concepts and ideas to try out and test. And you can list those here as things that you think may be able to influence the secondary driver, and you're likely going to have to do multiple of these to make an influence on your primary driver and improve your aim. How do you decide what kinds of interventions or things that you're going to change concepts you're going to test? And this is going to be one of the critical pieces of improvement work, is that as you have come up with the key drivers and you understand better what's driving the problem that you're trying to improve, you're going to think about changes to make. And as we'll talk about in some of the future sessions on testing, there's a very kind of specific way in which you want to try to change, for example, a specific process and test it out in a small set of patients, maybe even starting with just one patient and see how it works, and then maybe try on every baby that week or every baby that over a couple of days, and then kind of expanding your testing to where you get more confident that whatever change you made is going to work. And often you have ideas of the changes you want to make, but there's a list of change concepts, and this is something that is derived from the group that came up with kind of the model for improvement. This is from the Improvement Guide, which is a great book. It's in the bottom right here. That is excellent reading for those that want kind of a deeper dive into QI methodology, and it's really kind of a very nice overlay of the model for improvement. But these are some ideas if you're thinking of, or your team's trying to brainstorm of, what are some changes we can make. These are some of the things that come up. This is applicable not only to healthcare, but all improvement work across healthcare and other industries. So some of it may not be applicable, but things that relate to managing variation, so standardizing approaches, reducing variation, reducing waste, improving workflow. So a lot of kind of buckets that are color-coded that may help you to kind of think of changes and change concepts that you're going to go on and test. If you want more on key driver diagrams, the IHI this is a link to just a short video about kind of using key driver diagrams, and it's by Don Goldman, who is an infectious disease doctor and who's also a part of the Institute for Healthcare Improvement, and has done a lot of work in this area. So I just wanted to add a link there for those interested.
Thank you, Dr. Patel. Does anyone have any questions about that? If you do, you can press *6 to unmute yourself.
And I'll add, we'd love to see what if some of you have worked on this or plan to work on it, we'd love for you to share it with us and see what you're doing and kind of what you're doing. So please, share driver diagrams if you've come up with any, or if you're planning to over the next month or two. Please, we'd love to see what you're working on.
Okay, well, I'm going to go ahead and move over to the next section. I'm sure y'all will think of questions, and if you do, we'll have another Q&A or discussion section at the end, so you can stay on and ask it there. Of course, email us as well. But I wanted to go ahead and introduce our next presenters. We're going to have Brittany Smith. She's a NICU nurse manager at Northeast Georgia Medical Center, as well as Angie Reese. She's a team lead peer recovery coach. They are going to be talking about the work that they've done at Northeast Georgia Medical Center. So Brittany and Angie, y'all can, your lines are muted, but you can press *6 and that should unmute you.
Hey, can you guys hear us?
We can. There's just a little bit of feedback, though.
Okay, try that. Is that better?
Yep, that's great.
Okay, perfect. All righty. Let's see. Oh, perfect. All right. Well, thank you, guys. We hope that you will learn a little bit more about what we've done here at Northeast Georgia to really reach out to these moms and help these babies. So we don't have any conflict of interest. And the objectives for this presentation is we hope that you are able to discuss evidence-based practices for your NAS, also assess some personal perceptions of you and your staff, and discussing the impact of recovery language and culture, and then also be able to describe some benefits of peer recovery coaches here that we do here in the NICU. So we kind of want to talk about the beginning of where our NAS task force actually started. And so when we actually created our task force, it consisted of our NNP. We had some registered nurses, our clinical staff, We actually had a physical therapist. We had our pastoral care, and also our chief neo, which is our medical director, and so that's kind of where we started. And the first step was that we recognized that we were getting an increasing number of our NAS babies, and we wanted to see what we could do to really help that and address that population. We did participate before it was mandatory, the SINS, which is basically the state electronic surveillance system that you do. So hopefully your hospital is participating in that. We did actually do volunteer reporting before it became mandated. And then also, as our task force actually grew, we actually included other multidisciplinary team members. We ended up getting a representative from DFACS. We also had someone from the Family Treatment Court, and then also Partners for Drug-Free Hall, as well as Georgia Council on Substance Abuse, which is where we were able to really get connected with our peer recovery coaches. And so we kind of started with a small team of just here in the hospital, and then it quickly migrated to multidisciplinary outside of the hospital as well. And we met once a month for about an hour at a time. Other people that we actually evolved with was our VITA community partners, and so we actually had a representative that was coming and attending every month so that we could hopefully try to help moms get into a VITA. And we talked about some of the other representatives, but really getting everybody all at the table was very interesting conversation, and we were able to get a lot of work actually out of that meeting. So I wanted to really kind of touch a little bit about our average length of stay and where we started. So when we started the task force, we were currently treating babies with methadone, and their average length of stay was at 37.6 days. We did a lit review, looked at to see basically what other hospitals were doing. We started treating with morphine, and we were able to get our days down to 25.4. We continued doing some further work that we'll kind of discuss. And then last year we are down to 19.3 with our average length of stay, and we had 86 babies for the year of 18 for that. So besides doing the task force, some of the things that we completed were education and standardization of our education. So one of the things that we participated in is we had our staff complete the Vermont-Oxford Network, the NAS training. So we made that a requirement for our NICU staff. It started out as voluntary for our labor and delivery, mother, baby, and pediatric staff, but that actually turned into mandatory now. So all of our staff here in Women and Children's actually complete that NAS training through Vaughn. Other things that we did as far as standardization and education was the non-pharmacological treatments. We also started a NAS order set. And we created our policy so that everyone had the standardization for the NAS scoring, as well as understanding what kind of medication and treatment and guidelines were. And then the big thing that we also did with our staff education is we introduced the swaddle bathing, and we really educated staff the importance of swaddle bathing. Neonatal touch and massage, we have a physical therapist as well as one of our nurses who is actually certified in neonatal touch and massage, and so what they did was they were able to implement some basic skills that we did in our annual skills checkoff for our staff and able to teach them how to soothe these babies. Also with that, we included the swaddle bathing, so that was something that we included in our skills, is making sure that everyone had the same education and standardization of the swaddle bathing as well as the touch and massage. The other thing that we did is we started doing some guest speakers, and so we had the director for Emory Maternal Substance Abuse and Development Program come. And then we also had a PhD candidate from the Infant Mental Health Specialist. And then we also had Neil Campbell, who is Executive Director for Georgia Council on Substance Abuse. So we did several speakers that we had and come, and they spoke to not only our NAS task force, but we also included women and children staff that were interested in learning about what they were seeing outside of the hospital. Prenatal education, so one of the things that we worked really hard with is whenever we have a mom who is on methadone that is referred to the hospital, we actually have the prenatal consult that's very structured. So they come, they get a tour of the unit, they meet with a provider, and then also we give them the Guide for NAS Families, which is actually from the Ohio Collaborative. And then we also give them some information for the Vaughn NAS training, and so things that are geared towards parents. The neonatologist that is here does a consult with them. They give the information. They also usually meet with our physical therapist and kind of explain the role of what to expect, how to care for their baby. We also have them sign a family agreement, and so that partnership form that we created, we actually took it to our Voice, which is a structured government system here in the hospital. And so for these particular moms, they actually sign this family agreement that basically lines out what they should expect from us as staff and what we expect from them as the mom. And we expect for them to be present in the care and for them to be able to be here as much as possible, because we do encourage them to be here as much as possible. Other stuff is we do have education that we give them, which is the warm line that I'll let Angie kind of explain here in just a minute. And the other thing that now that we have our peer coaches, we actually invite them to the consult. And so they are able to come and speak with moms at the consult for them to have that kind of peer support if they're not already involved with a peer support prior to the consult. And then I'm going to let Angie speak for just a minute about kind of what they do with the consult and what your role is.
With the consults, I'll tell you a story really quick. We had a mom that came in last year, and she gave birth to the baby, and she and baby tested positive for several substances, and baby had to go to the NICU. And apparently, mom's friend was here when the nurse was talking to her and heard the conversation and said to her, "You know, they're going to arrest you, right?" And mom said no, she didn't know that, and she panicked, and she got up and left the hospital and abandoned the baby here. And at that point, we realized if we could get to these moms before delivery, while they're still pregnant, we can help prepare them for what they're going to face at delivery. If the baby has to go to the NICU, they often think that the baby can detox as quickly as an adult, and that's not true. So we can help prepare them for the time that they're going to be here and what it's going to be like. We also help them navigate through their defects cases. And we hope that them preparing them ahead of time, it makes it easier on the nurses, because we found that some moms were getting belligerent or just upset with the nurse when they found out how long they were going to be here. And obviously that's not the nurse's fault. So when they kind of come into it prepared, that helped. We were able to get a hold of that mom. It took us about 3 weeks to get a hold of her. And when we did and explained to her that, she would not have went to jail. And, of course, at that point, DFACS, was already in taking custody of the baby. But she did go into a treatment center, and she's still in a treatment center and planning and supposed to be getting out soon. So hopefully that story will have a good ending. I mean, meanwhile, the baby was put in a foster home, and she's been working a plan to get the baby back. So we'll see if that happens. But I just think if we had been able to get involved a little bit sooner, it would have had maybe a better outcome. So we recognize that, and so we started reaching out to get in touch with the moms prior to delivery, and we offer them support. We can give them collectively in our office. We have all kinds of resources that we've personally experienced or come across in this field of work, and so we've compiled a whole bunch of resources. Like we know which rehabs you can take your baby to, or which rehabs will allow you to have a job, or versus you can't. We've got a good list of resources to help them with, and we want them to self-direct their recovery, because when you have input into something, you're more likely to participate in it and be successful at it. And we don't push any particular path of recovery. We believe that there's all kinds of different paths of recovery. Different things work for different people, and so we let them self-direct and tell us what they want to do. And then we just try to give them the support and resources to do that. We have also had the bandwidth to even be able to, been allowed to go to court with them and to DFACS hearings and give them support. We can meet them outside of the hospital if they want to meet and talk. When they're in the hospital or the baby's in the hospital, we will meet with them daily, every day. And we just try to help take care of mom, while the nurses are taking care of the baby. That's it for now.
one of the things, too, that we did, too, that is we started a perinatal work group. And so, we all have enough meetings to go to, but at the end of the day, we had, besides our NAS, this is another one that's very productive. We have the OBs at the table. We have our neonatologists at the table. We have the pediatricians. We have our Women and Children's Director. We have our clinical practice specialists. We have the managers there at the table. And so that is one other option that we really try to talk to in that meeting, is to talk about what our plan is for these moms, because we want the OBs to be able to provide support to their moms just as well as we want to provide support for the babies and do what's best. And so with that work group meeting that we have, we only meet quarterly for that one, but we always give an update and really discuss what our standard treatment is for these babies and moms and how we can better serve them. Other stuff that we really tried to work with our staff as far as advancing the standardization for these babies is the change in staffing assignments. So if we have babies who have higher Finnegan scores, such as if they have, if they're scoring greater than 8, and we're really not able to get that score down with non-pharmacological treatment, we really try to lower the patient ratio. So we typically will try to have one nurse have 2 patients, so that they're able to spend more time in trying to keep that baby from going on morphine treatment if needed. The other thing that I talked about was we did create a NAS order set. We do have Epic here at our facility, but we were able to create an order set specific for these patients so that it tells us when we can do our scoring, when to notify the physician, etc. Other thing that we've been doing is trialing the Eat, Sleep, and Console. So we've been doing some data on that and really comparing it to the Finnegan scoring to kind of give us a better understanding of how we can do more of a cluster approach with that. Also, parent, infant, room, and in together. If the baby meets certain criteria, we do have some parent, infant, room, and in rooms. We typically use those for our babies who have been here a while, for the parents to room in for those babies. But sometimes for our NAS babies, if we do have a room available, sometimes we are able to allow them to room in. Also, depending on how stable they are and the type of situation that mom is in, we have been able to transfer them to the pediatric floor and able to wean them on the pediatric floor, being followed by our physician, our neonatal physician here. So, talked a little bit about the family partnership agreement. That was an agreement that we went through, like I said, voice, and we really want to make sure mom has a clear expectations from us, and for her to understand that we have clear expectations from her as well. We also do have a cuddler program here that is through our volunteer services. So we do have a core group of volunteers that are specifically trained. Our nurse educator for the NICU trains our cuddlers, and our peer coaches are also trained as cuddlers as well. And then I talked a little bit about the perinatal work group because that really helps having everybody there at the table for them to know that we have this program and kind of know what the work we're doing to better for their moms and babies. It really has made a difference on them giving referrals to moms that are on methadone or on opioids, and so it really helps us to have that. And then last but not least, we talked a little bit about our peer recovery coaches. And I do want her to speak here in just a minute about some of the recovery language and culture, because that was one of the big things that we know is a barrier for success for these parents, is really having a culture change, and that's something that we went through here. And so with our staff, really having a mindset change, one of the things that we really noticed is, as I was talking earlier about having our guest speakers such as Dr. Cole and Neil Campbell from Georgia Council on Substance Abuse, when they actually came in and actually were able to educate our staff about recovery and understanding the pathophysiology behind it, it really helped with some of our mindset change. And Angie, if you don't mind, I'm going to let you kind of speak about the recovery language training that they came and spoke with us about.
I'm talking about the mindset change first. I'll say that first of all, I think that the culture here was, when I came on board, had really changed from what I'd heard it was before. I think that also part of that mindset change was that we had the chance, as we started to build relationships with the staff and interact with them, at some point we had a chance to tell them a little bit about our story of addiction and recovery, and they seeing that we are functioning productively in society today and that people do recover, I think helps with that mindset change as well. So the recovery language, we do training on that because the way you talk, the things that you say to a person, even certain words, it kind of can make them feel judged. We want to say things to people to not make them feel like negative about themselves or negative about the situation, so that they don't, especially here in this kind of setting where we've had, moms might feel judged, and that would keep them from being at baby's bedside, as much as they need to be because they don't want to come in. And some of the language that I'm talking about is like instead of, we don't use the word addict or junkie. We might say someone who has substance use disorder or a person in recovery. By the way, I'm a person in long-term recovery, which means that I haven't used any mind or mood-altering substances in almost 4 years. And let's see, we also, instead of saying to someone like, what's wrong, we might ask them what happened so that they don't feel, so it's not like an accusatory way of asking, what happened instead of what's wrong. Instead of saying someone's delusional or paranoid, we would probably say that they are experiencing an alternate reality or a reality that is different from mine. Instead of saying drug abuse, we say substance use. It's just little things like that. The language can make a difference in how the person perceives that you're looking at them or judging them, and that makes a difference in recovery as well.
And part of what we're doing, too, is expanding the recovery culture. Like I said, with the perinatal work group meeting, we're also reaching out to all of our OB offices. The peer recovery coaches are doing a phenomenal job about outreach. They're actually reaching out to pain clinics, our local health departments, and really trying to partner with DFACs. And so that has made, I think, a big difference with trying to get everybody all at the table so that everybody is in support and really trying to help our moms into recovery so that they can better take care of themselves and their babies. And then if you want to share one more story.
Okay, let's see. Actually, I got two, but one's really short. So one story I had is about a mom that had come in, and she had found out she was pregnant when she was here. She had come in on an overdose, and I had went in to talk to her and try to start working with her, and she seemed receptive to want to get in recovery and do the right thing for this pregnancy. And when she left the hospital, I had a hard time getting in touch with her, and she had sent me a friend request on Facebook. So I'm kind of able to do the things that might be inappropriate for medical staff to do. I can reach out to her and contact her, communicate with her in alternative ways that the medical staff wouldn't be able to do. So she had sent me a friend request on Facebook, and she would never answer my calls or answer my text messages. And on Facebook, she was always playing this little word blitz game, and she would always send me a challenge to play it. And so one day I started playing against it with her, and then a few days, and I was just barely beating her every time. So just a few days later, I sent her a message and said, I'll make a bet with you. If I win this set, then you've got to do a 5-minute video call with me, and if you win, then you get to pick something. And she said, okay, if I win, you got to order me a pizza. And so we said, okay, and I beat her, and so she had to do a 5-minute video call with me. And that video call led to a relationship with her, in recovery. And she had said, I didn't think it would be so easy to talk to you. I was just really embarrassed. And so the video call went from there. And now she's close to 9 months pregnant now. And she's been in recovery for about 5 of those months, completely off of. She went through a medical detox, everything, completely off of everything. And she's doing really well. And I check on her all the time. So that was really good. And then we had a mom who had her baby, and DFACs came in to take custody of the baby. And this is the first mom that we started working with prior to delivery. And so I had worked with her for about 5 months, and then when they came in and they took the baby, and because she had been on methadone for 5 months and kind of in recovery, we didn't expect that. And she was very devastated. And I think that if I had not had the relationship built with her already, that she would not have went to her court hearing the next day with DFACs. She was very hopeless and distraught, and it literally took me talking to her on and off all day to convince her to go to the hearing the next day. And so I went to the hearing with her in support, and if she had not given up the day before, then we got to the point of the hearing, and they denied visitation for her. And the lawyer was walking away after he had told her, they're not going to let you have visitation. And I tried to talk to her about how important it was for her to be bedside and to speak up about that, for visitation. But when he told her that, I could just see her just kind of like, just her shoulders sagged and just kind of deflated. And being in a legal setting was kind of intimidating for me because I don't know the law, and I'm not a legal expert. And I got this lawyer telling us this, but he turned around to walk away, and just kind of like the last moment of courage, I was like, hey, wait. And so he turned around, and I was like, I'm not a medical expert. I don't have any medical training, but I do know from being around these babies that the more mom is at the bedside, the better the baby will do. The more mom can be there and cuddle the baby and all that, and explain the NAS to him. And he listened to me, and he said, would you be willing to tell that to the judge? And so I did. I went and told the judge that, and they ended up giving her visitation daily. I think it was 3 hours every day, and then they wanted to expand it, and that baby was here for a minute. It struggled, but she was able to be bedside. And I think at the hearing, if I had not been there to help her advocate for that, then she would have gave up then. There's just been a few times where I think she would have given up, and at this point she is still working a case and hoping to regain custody of the baby. So that's a couple of my success stories.
And so I guess if you guys have any questions, I don't know if you may have some questions as far as barriers to what we've implemented here, or barriers to anything we've talked about, or if there's anything in particular that you're wanting to hear more information about.
And just a reminder that if you do have a question, you can press *6 and unmute yourself to ask it.
Hello, this is Nancy from Wellstar Kennestone.
Hey, Nancy.
Hey, I just wanted to know if you would be willing to talk one-on-one about your process through navigating with the parents beforehand.
Yes, absolutely. We can do that.
That is one of the things that has sparked the most interest for me right now.
Yes, we can do that.
Yeah, because it does make a difference. I mean, I'm able to make a connection with the moms that the nurses sometimes can't, just because I have that lived experience and they feel like I get it more. And I actually went through a drug court program myself. That's part of my recovery. And I remember that I had counselors who had never used substances before, and I thought they were great counselors, and I enjoyed the classes, and I got something out of it. And then one day we had a counselor come in, a new counselor, and she had actually was a graduate of the program and in recovery herself. And I could just tell the shift in the class, because everybody knew that she understood kind of where we were coming from, and it was just a different dynamic. And I think the moms open up to us in ways that they don't with nurses, because they're scared to, and they feel ashamed, and they're scared they're going to get in trouble. And they're brutally honest with us, I think, a lot of times, and they feel like we can understand that.
Well, thank you very much. I'd be most interested how to get your contact information so that we can chat further.
Yes, absolutely. And I can kind of go into more detail, too, Nancy, about what we discuss in our consults when these moms come here and how the physicians refer them to us, et cetera, if that's what you're looking for.
Perfect.
Yes, so have a question. What is the size of the staff for the NICU? I currently have 89 nurses. For labor and delivery, I think they have around 90-something. We do approximately about 4,000 births per year. It says, how many nurses did you educate, and can you please share the family? So the nurses, I will say it took a little bit to get that implemented with the education, because there is a large number. So what we did is, when we did the rollout for us, we created a slide that all of us used in our monthly staff meetings. And it gave them the date of when it was due, and we did give them a reasonable amount of time to complete that. I believe we gave up to 6 months for all of the staff to complete that, and it was completed. They can complete it while they're here at work, but we did have that be a mandatory one-time education, but we did give them quite a little bit of time to complete because between our numbers as well as mother-baby, we also have another facility that does it as well. So we all just shared the same staff meeting, so we had the same consistent message and gave the same due date for all of our staff. And yes, we can work on trying to share the family partnership agreement with you. All right, we got a good question too. We have a question here. It says, wants to know what we discussed sharing stories of recovery to help with culture change in the hospital. Oh, can you guys still hear me?
You cut out for a second, but we can hear you now.
Okay. We have a question that asked if we would discuss sharing stories of recovery to help with culture change in the hospital and what interventions will you use for staff that remained unreceptive. And so I can kind of speak to that, but I'll let Angie share too. So some of the things that I use with the culture of my staff that is personal to me is I actually fostered a baby that was withdrawing from NAS back in 2011, and I'll just be honest and try to make it short and sweet, but my husband and I had issues with infertility, and I had graduated with my master's degree, and we ended up fostering a newborn and her 4-year-old sister, and nobody knew that the baby was withdrawing from NAS, but because of me being a NICU nurse and my education, I realized it very quickly, the signs and symptoms. And so I can tell you from a personal experience that was one of the things that was very close to me on why I was very interested in ensuring that this program really was successful. But I think being honest and sharing with our staff, one of the big things that was really key to us was we had one of our former moms who had not one but 2 babies that was down here for quite a bit of time that was withdrawn from substances, and she ended up getting accepted into Avita, and she came back to our NAS task force and shared her story, and it was very eye-opening for the staff because she was very brutally honest with us, as Angie mentioned earlier, and she said, when you talk to me and treat me like an addict, then I go out and use because I'm going to be an addict. And so that was kind of her overall message. And so with her being in recovery, I think it really helped support the staff to understand that we had a mom who had not one but 2 babies in the unit who was actually physically arrested in our unit out here at the hospital. And for her to be able to go through recovery and come back and share her story and really kind of give us some opportunities, I think that was something that really helped with staff who was unreceptive to that. I also think some of the things that helped was actually having Neil and Dr. Claire Cole come and talk about their experiences and kind of give the background to the pathophysiology of addiction. I think that helped a lot with the mindset change as well. And then, Angie, if there's anything else you want to add?
I was just going to say, I definitely think that a big part of the culture changes is people hearing the stories. The recovery stories are very powerful, and it's also what interventions did you use for staff so when you started to change the culture, did you have people that were non-receptive to it, and what did you do?
We did. Basically, what we try to do is we really try to talk to them and say, you know, it's hard because I had the same feelings. I was very upset that I was taking care of a baby for a mom who used drugs and knew she was pregnant, and I could not understand why she didn't stop using. I'll be honest, I thought she was a horrible person, and that was my own personal afflictions. So I think having to set that aside and really understand that an addiction is a disease, and I think that was really hard to do, but once I got there and really understanding and realizing that it's not just a term that people use, that there really is science behind it. And I think for us as nurses that really helped. And I will tell you personally, we had a department that was really kind of unreceptive to our peer coaches at first, honestly. And one of the things that really helped is we had a mom who had went through the ED who was homeless and was currently high, was using. They discharged her. She found her way over to labor and delivery, and she came in and was just sitting in the waiting room and didn't have anywhere else to go. And basically, she basically sold herself, her body, for drugs, and that's basically how she was living. She presented an L&D and triage, and she had just been discharged from the ED. They didn't know what to do with her. They called me and said, hey, I have this mom up here. I really don't know what to do. Case management can't seem to find her anywhere to go. So I then, in turn, called one of the peer coaches that was actually in the ED before they even got to the NICU and said, hey, we have a mom who has nowhere to go. She's homeless. What can we do to help her? And the coach came over here and was able to find her a place to stay after 2 case managers could not work on getting her out of here, and nobody really knew what to do with her, honestly. And so I think that was one of the things that really helped was staff who was very unreceptive when they saw that happen, and that mom actually went and got off the streets, not only off the streets, but they were actually able to get her in recovery. I think a lot of times sharing the stories and actually hearing from people who can say, that they witnessed that or that they were a part of that or that, they actually saw something happen with their own eyes. Because I think more often than not, somebody either knows a family member or a friend's family member, somebody who is suffering from addiction. And so I think a lot of times we have our own personal biases, which can truly be a barrier into making this successful.
And from the recovery coach standpoint, I would say that when we first started, my feeling was that you could definitely tell that they had been taught, trained on the culture. That you could tell that people were on board with it, and the people who were not or who were resistant, it was quiet. You could feel it, but there was nothing said. You could just get the vibe I could get the vibe from a couple of the nurses, and so I just recognized that they have a reason that they feel that way. It's either, like Brittany said, they had something personal in their own life that made them feel the way that they did. I would imagine, that nurses work very hard and go to school for a long time to get their badge that gets them in the NICU, and that's not how I got my badge. And if somebody felt, resentful of that, I could understand it. So I just knew that it wasn't going to happen overnight, and so I just, I'd come in and we'd come in every day and make like a round through the NICU and say hello to everybody and ask if there was any moms we needed to talk to. And doing that, we were able to start building relationships and just, stop and talk to a nurse for a few minutes. And I just waited until I got the chance and the right time to get to those nurses where they had a moment where they stopped and said hello or, started talking to me about something. And when I could tell my story, I took that opportunity to do it. And I don't feel resistance from them anymore. I don't know what if it's a story that changed or just the constant presence there and the work that we do, but it just took time. It took time with those and just hearing the story, I guess, and seeing that that it works.
Well, I want to say on behalf of all of us that Brittany and Angie, that was a great presentation, and we really appreciate hearing about the work that y'all have done at Northeast Georgia Medical Center, but also just your personal stories, too. If anyone else
Thank you guys for letting us share today. We appreciate your questions, and if there's anything else, just let us know, and we'll be glad to answer them, even offline.
This is Dr. Levine. I just want to say that was a great presentation, and to point out that, the treatment protocol is the easy part. All the other things that you're talking about that come into play are really important, and maybe not as easy for some of the rest of us to get into place. So we can take some great pointers from you.
We appreciate that. Thank you so much.
Yeah, and this is Ravi, and I couldn't agree more with what Dr. Levine said. I think culture change is probably one of the most important things as you try to improve care, and I think you've done a wonderful job on kind of tackling that head on, so congrats.
Thank you. And I will say, as far as a leader, one of the things that I've encouraged my staff to do is if they have any issues or if there's something that they're battling with, maybe they have a family member that has an addiction that's not in recovery, I encourage them to come talk to me, and I'm here to listen. So if they're really struggling, with the culture that we're wanting to change in our unit, I've encouraged them to come talk to me so that I can speak with them about that. And I will say a lot of them who are unsure, they actually start to participate in some of these, speakers that we have because they decide they want to learn about it. And when they know that it's, I have an open door policy about that, it really helps for them to come and know that they're supported, even if they don't support this program in their point in their career.
Hi, this is Dr. Cynthia Cabrera. I'm the medical director of Northeast Georgia Medical Center, and I just want to say how proud I am of my staff and how far they have come along. It has been a struggle, even for us as providers, to change our mindset towards these babies, but I think we are continuing to work forward.
And I think we have a question. We've had a couple things they wanted to know if we could share our family partnership agreement and also our EPIC order set. So let me get some information, and I'll try to get with Caitlin to see what we can send you guys. If you are interested in that, I'll see what we can get to share with you guys.
Yeah, whatever you guys are able to share, I'll be happy to send out to all the hospital teams.
Okay, perfect. Yes, I will work on that.
Great. While y'all are thinking of any final questions just in the past few minutes, or in the last few minutes, I wanted to give just a quick update. You all will be getting your Vaughn monthly lesson reports hopefully within the next day or two. Vaughn should be sending it to me like any minute now, and I'll send that out to all of you so that you can see how far your staff are with the lessons. And just a reminder that those reports, there's a kind of like a week and a half delay, so those reports will show you everyone's progress through August. So if people are saying, oh, but I just watched this, well, it's probably because I watched it in September, and it'll show up on that next report. I'll send you too in an email the instructions for who to contact if you're wanting to add people, remove people. Vaughn did let me know that there's someone at your hospital who has rights to remove anyone, to remove their access. So if someone leaves or if they just don't need to be on your team anymore for whatever reason, I can help connect you with Vaughn to figure out who that person is. It sounds like someone was automatically assigned that role. So I can work with you to figure out who that is and who, maybe if you want to change who that person is to, we can work on that too. So I'll send that out in an email, but just something to keep on your radar. And then also we recommend having at least 5 core members on your team. There's 8 hospitals, I think, that have fewer than 5. So you'll see that when I send out the lesson report, and I'll make a note of it too when I send it to you. But if you're one of those, especially if you're a larger hospital, really be thinking about who else you can add. Like we just heard on this call, it's really important to have a lot of your staff trained. So we think that'll be really beneficial. So I think that's the last update that I had. Are there any final, I don't see anything in the chat box, but any final questions or thoughts from anyone before we go?
Just a quick reminder about Smart Aims. I know we've talked about Smart Aims before, and a lot of you have sent in Smart Aims. But remember that the mnemonic is specific, measurable, attainable, relevant, and timely. So to have a SMART aim, SMART aim is your target, it's what you're going for, and in order to hit the bullseye, you really have to have all those components in your SMART aim. So make sure your aim has a timeline attached to it, make sure you have metrics attached to it, make sure it's specific and not just general, we're going to improve the situation kind of thing. So just a reminder for your SMART aims to help you reach the target.
It's a great reminder. Well, it is 3 o'clock, so we can go ahead and end the call, but if you have any final questions, feel free to email me, and I'll be sending out all the follow-up information from this call. But we really appreciate all of our presenters and hope that this has been really helpful for you all. So thank you for being on today.